Hello, everybody. Welcome to the T1D speaker series, and I'm labeling this the tough topics, and we're starting off with a tough topic. We are talking today about gastric and digestive issues in type 1 diabetes, and it's significant enough that you should want to know about it. You may be already knowing about it, and we're here to learn a whole lot today. I forgot to put a slide in about me, and I realize most of you don't know me because I'm more involved in the DIY looping community. I've had type 1 diabetes for over 56 years, longtime JDRF supporter since the beginnings of the 1970s. I run a local adult support group for T1D in Orange County, California, run an active blog called the SavvyDiabetic.com, wrote a book about surviving being in a hospital because it's dicey to be a type 1 diabetic in the hospital. I started a study group about T1D and aging because I think that's a significant issue, and we're getting some traction doing some projects at UCSD and University of Utah. I've been on the DIY Riley link since 2016, and I started the Loop and Learn Facebook support group for the DIY community, as well as a website called loopandlearn.org, and all our videos are up on Loop and Learn on a YouTube channel, and you can all follow up on that later on. So that's enough about me. And I started this with the concept that the longer you live with this disease, things happen. And this disease is capricious, it is unrelenting, and it's difficult. And everybody who's on this call who's living with type 1, congratulations, you're here today. It's a difficult disease. We do as well as we can to be optimistic and get the best control and do all the right things, or not, but it's a tough one. And so I appreciate everything that you all do. I do not ever think for one moment it's an easy thing to manage. But I think if we tackle some of the tougher issues that possibly affect us as we age or even as children, we will know more, and we can help our doctors help us because they don't always know. So if there are topics that you want to hear about, here's my email address. It's joanne@thesavvydiabetic.com. Just shoot me an email saying, boy, I'd like to know about this. I'm thinking of tackling neuropathies or other things that nobody wants to talk about, but we're going to talk about them here. I have some helpers today. I have some co-moderators that'll help us with the Q&A. Teresa Hastings is part of the diabetes community. She has been since 1998. She leads multiple support groups for women with diabetes, both online and in person. She currently serves as social media manager for Diabetes Mind, which is an amazing website. She is a mom to two adorable kids. She's a wife, and she raises chickens. Plus, she's a full-time T1D and a full-time DIY looper. Rachel Gerlin is a medical writer for Insulet Corporation, makers of Omnipod. She recently graduated in 2019 with her PhD in biomedical engineering. I got to see her dissertation defense, and her research is in beta cell replacement. She also has a sister diagnosed with T1D almost 20 years ago, who's also a DIY looper. And then we have Barry Williams. His first career was in medical diagnostic production, initially for clinical chemistry and later diagnostic products for microbiology. He then moved on to his own company for personal care product production. He is a T1D, a DIY looper, and a world traveler. He just got back from 3 weeks someplace across the pond. These folks are dear friends of mine. I'm honored to know them. I'm honored with the effort they put into our DIY and self-supporting communities, and a great appreciation for y'all being here today. So let's get on to the main show. I'm thrilled about this today. The topic is gastric and digestive issues in type 1 diabetes, and that's a big topic. There's a lot to talk about, and it spans the full range of diabetes from diagnosis all the way into adulthood and senior years. Dr. Marina Basina is clinical professor of medicine, endocrinology, and gerontology and metabolism at Stanford University. She is a clinical endocrinologist and clinical researcher with a focus on diabetes management, thyroid, and adrenal conditions. Her primary interests are in type 1 diabetes, diabetes technology, and diabetes in pregnancy. Dr. Basina is board certified in endocrinology and internal medicine. This is where all the good stuff comes. She received numerous teaching awards and the Stanford Hospital Award for Excellence in Patient Care. If you've ever been on a Zoom with Dr. Basina, you just always learn something. As if she weren't already busy enough, she is an active member of the medical advisory boards for several community diabetes organizations, as well as a medical director of inpatient diabetes program at Stanford and a chair of the diabetes task force. I don't know when she has time to breathe, but thank you for doing what you do. Dr. Linda Wynn is a clinical professor of medicine, gastroenterology, and hepatology at Stanford University, with special interests in gastroparesis, chronic nausea, cyclic vomiting, irritable bowel syndrome, autonomic dysfunction, and brain-gut disorders. This is all the stuff I've been writing about on my blog. This is exciting. She has been quoted as saying, "Food has always been a big part of my life. Imagine what life would be like if eating made you sick." I know you all can imagine this, because we need food to survive, and we are social creatures who revolve much of our lives around food. Not being able to eat impacts physical, mental, and social well-being. It is this intricate interconnection between the brain and the gut which drew me to the field of neurogastroenterology and motility. I read that and tears came to my eyes, like, oh my gosh, she understands. My research, she says, she continues, includes understanding the role and impact of physiologic testing on clinical care, exploring novel therapies for gastroparesis, and expanding the role of neuromodulation in the treatment of GI motility disorders and pain. This is powerhouse. I'm so glad you all are here today. You're welcome to have your cameras on, but we'll keep your microphones off. And if you have questions, please put them in the chat. That's what our co-moderators are going to be juggling after the presentations. And feel free to take notes. And again, thank you for being here. And I will turn this over to our guests. And I think Dr. Basina is going to be our first speaker.
Great. Thank you so much, Joanne, for a great introduction, and welcome everyone to this webinar or seminar. We're really excited to be here with you and to present this topic, which is very, very challenging. And we have been having a lot of challenges with our patients and trying to make all of your life easier as much as possible, but definitely there are a lot of challenges and a lot of unknowns. So what we will be talking about today is still subjects for research and still a lot of studies to be done and a lot of things to be investigated and solved. So if that's okay, I'm going to share my slides. And I will try, we wanted to make it informal, and I'm going to try to make it fast and maybe skip through some of my slides just to leave more time for questions. And then Dr. Wynn is going to take over and we'll be talking about some different topics and some different GI issues. And I'm glad we actually not even first decided on which particular topic to cover. We chose completely different ones. So I think you will have a large spectrum of the conditions too that we will try to cover today. So just to give you a little bit of the overview, that gastroparesis itself first was actually described in 1945. And the initial term was gastroparesis diabetic, and it was introduced in 1958. And then delayed gastric, in the definition or the definition of the gastroparesis itself is the delayed gastric emptying in an absence of mechanical or anatomic obstruction. It's more common in female than male. And in terms of the cumulative incidence over the 10-year period of time, it's about 5% in type 1 diabetes, but less so 1% in type 2 diabetes, but much less in the control individual, 0.2%. So prevalence overall is about very high, as you can see, close to 50% among type 1 individuals, and still really high among type 2 individuals as well. And hospitalizations rate is higher in individuals with gastroparesis, and mainly hospitalizations are for vomiting, dehydration, more common comparing to idiopathic non-diabetes related gastroparesis. Unfortunately, mortality rate are also higher in individuals with gastroparesis than the ones that don't have this condition. And increased mortality partly explained by other comorbidities, not necessarily the presence of gastroparesis. Just to give you a little bit of the overview of the anatomy of the stomach. So there are several parts of the stomach that are essential for food digestion. The body or the stomach and the fundus serves for liquid emptying and sort of accommodate and storage of for the food. The antral part of the stomach grinds the food. So it mixes it to very small particles to about less than 2 millimeters in size. And then for pyloric part of the stomach, it contracts postprandially to allow this grinding of the food in the stomach. And that pacemaker or the special cells of Cajal, they serve as a pacemaker of the stomach. And they convey the message to the smooth muscle when to relax and when to propagate the food. And this is the slide I got from Linda, from Dr. Wen. So it's interesting that both hyperglycemia, both high blood sugars and low blood sugars affect the rate of gastric emptying. And in the literature, you would see that stomach emptying is a sort of brake mechanism for how fast or how slow the glucose appears in the blood. And that mechanism is extremely important. And if it's impaired, then the actual appearance or disappearance of the blood, of the sugar in the blood could be impaired. And therefore, with the insulin given subcutaneously and some other hormonal changes that happen, it's really hard to match the food, this appearance in the blood of the sugar and matching with the insulin absorption and insulin timing of administration. So beta cells produce not only insulin, but the other important hormone that is produced in beta cells is the amylin hormone. And this hormone is also affecting the gastric emptying significantly. And you might have heard the medication that we use sometime for postprandial glucose control, which is an amylin analog. It's called Simlin, and we are using that occasionally in individuals with not with the delayed gastric emptying, but more of the fast gastric emptying to sort of delay that gastric emptying. In type 1 diabetes, amylin hormone is reduced along with the reduction of the insulin. And therefore, there is an earlier appearance of glucose in the blood. And that's why sometimes you would say, I'm so sensitive, I eat a little bit and my sugar spike really quickly. So again, this is one of the reasons why that is happening. And the rate of gastric emptying, as I mentioned, it's one of the major determinants of the postprandial hypoglycemia, hyper or hypoglycemia. And this effect of sort of bidirectional. So on one hand, gastric emptying, one of the major determinants of the postprandial hypoglycemia, but hypo or hyperglycemia. But on the other hand, glucose itself is affecting gastric emptying. So the higher the glucose, the slower the gastric emptying. The lower the glucose, actually the gastric emptying is fast. So that's why sometimes with the low glucose, it takes longer time for the correction of the low glucose because the stomach empties faster and body relies on the lower parts of the intestine for that glucose absorption. So may take longer time for that glucose to get absorbed. So gastric emptying phases for different foods. For the liquids, it's relatively quickly, but slower for caloric liquids. For solid phase, it's sort of two phases. So the first phase involves fundus in the body, and the second phase is the actual gastric emptying. So the normal is about 50% of the food is kind of empties the stomach within 2 hours and 100% within 4 hours. So the pathophysiology of gastroparesis would be, or delayed gastric emptying would be if 2-hour retention over 60% of food stays in the stomach. And after 4 hours, it's about over 10% stays in the stomach. And all those possible disorders, again, there are many, and Dr. Wen is going to be talking more about those, are affecting the gastric emptying. So it's not just one pathophysiologic process. Unfortunately, there are many of those involved. Now, the symptoms, interestingly, do not always correlate with actually what we find on the gastric emptying studies. In some studies, there had been shown that it could be some early satiety, some fullness associated with gastric emptying, but not nausea and vomiting, abdominal pain, or bloating. In diabetes and non-diabetes, all symptoms could be associated. So symptoms can vary a lot. And unfortunately, because of all those symptoms, a lot of psychological component to that as well. So with depression are more common, and that by itself can be affecting the symptoms. So here in this table, you can see with idiopathic gastroparesis, meaning no symptoms of no diabetes, or comparing with type 1 diabetes, so that you can see that vomiting is more common. And abdominal pain is actually more common in idiopathic gastroparesis than in the type 1 diabetes gastroparesis. But there is another condition that can cause fairly similar symptoms, and sometimes it's not easy to distinguish one from another one. So it's actually rapid gastric emptying, and we see this as well in some individuals. And it is fairly common in almost 20% of patients with longstanding type 1 diabetes, and in some patients with type 2 diabetes. And approximately 20 to 37% of patients with gastroparesis may have upper abdominal pain symptoms due to rapid gastric emptying, not to delayed gastric emptying. So we're thinking clinically it could be delayed gastric emptying, but in reality, it may be the opposite. And it's important to recognize what exactly could be happening with the patient. And I have this table with some prevalence that I'm just going to skip that data just to have more time. Now, glycemic control, how important it is to maintain the normal gastric emptying, as we said, because both high and low blood sugars are affecting the gastric emptying. And what can we do to try to keep glycemic control as good as possible to sort of minimize those glucose fluctuations, to minimize the high and low glucose effect on the gastric emptying itself. So multidisciplinary approach is important. So we want to include everyone, certified diabetes educators, nutritionists, psychologists, primary care physician, gastroenterologist, endocrinologist, definitely compassionate family member. That is very important. Some oral agents for diabetes may not be recommended because the pharmacokinetic and pharmacodynamic may be affected by absorption. And I know we are using some of that type 2 diabetes medications for type 1 diabetes. And I'm actually a big proponent of adjunct therapies in type 1 diabetes because I don't think one insulin hormone can substitute all the functions that are need to be replaced and covered. So insulin therapy is a standard of care for that. And for medical therapy, we're using anti-nausea medications, avoiding any pain medications too, because they further slow down the gastric emptying. Low fat, low fiber diet is important. And that's what I see a lot that is the opposite done in type 1 diabetes frequently, because it feels like I need to have lower sugar and I need to have slightly higher fat and protein and fiber to slow down my stomach absorption, which is actually should be the opposite. And glycemic control, ideally less than 180 with avoidance of hypoglycemia. Currently, we use a lot of CGM, and you're all super savvy group with the use of the technology. So all the loops and the closed loops and insulin pumps with CGM are super, super helpful. So we usually, and I advise this a lot to my patients, if you do have severe symptoms, go to this phase diet, start with liquid diet and try to get everything kind of calmed down, start feeling better. Do it for 1 to 2 weeks. It could be less than that, depends on how much you feel better. Then add the stage 2, some limited diet, and then go to that maintenance diet. So unfortunately, there's not much data out there about the use of technology and gastric emptying, or specifically gastroparesis. We do know that continuous glucose monitoring devices are super, super helpful, and they can prevent or alert us if you go low or high glucose overnight or during the day. Sometimes, most of the times is great, but a lot of the times, as you know, it creates more anxiety. And if the glucose are going high, starting bolusing and correcting more, and then eventually getting insulin stacking and eventually going low. So even as technology is super helpful, but sometimes it could be harmful if we overreact on this technology. So this is a very small study that looked at the using of the extended boluses or combo boluses with only 10 to 20% of the bolus given upfront, and the rest extended over 2 to 6 hours. And we know that this, not with all the current FDA-approved closed-loop systems, is possible, and with the loop, it's maybe challenging as well. For loopers and open APS users, how to set it up. But this was a small study looking at type 1 diabetes with gastroparesis and with gastric pacemaker, how you can see the variability of glucose levels, and with use of the combo boluses and closed loop system with sort of, or multiple boluses given to sort of mimic the closed loop system. Mimics the extended bolus. You can see how markedly control improved in this particular patient's very small patient group. So Dr. Wynn and I did this study, which was a fairly labor-consuming study, but it was really great because what we wanted to look at how feasible is tight glycemic control for those individuals who have a lot of fluctuations in the blood sugar. So we did it back in 3 years ago, maybe, Linda. So this was the study called GLUMIT. So it recruited 45 patients with type 1 and type 2 diabetes with a hemoglobin A1C average mean was 9.4%. And we followed those patients really, really closely with, they did gastric emptying studies before, during, and after the study enrollment. So we used, the study was before closed loop officially was approved for any of the pumps. So we did it with Medtronic older version of the CGM, and with Medtronic older versions of the pumps. I think we used 512 or one of, so the older ones. So it was a 24-week trial to look at prevention of the hyper and hypoglycemia and association with improvement of the symptoms. So with the sensor augmented pump therapy. So as you can see for the intervention phase and for screening phase, so you can see that hypoglycemia was significantly reduced. Hyperglycemia was significant, euglycemia was increased, and hyperglycemia was reduced in those patients. And you can see also the hemoglobin A1Cs amazingly decreased in the patients who were, we followed them weekly, or even some patients were twice a week, and they had constant access to the study coordinators and to our CDEs. As you can see, at the same time, we used gastroparesis cardinal symptom score, and all the symptoms in the patients in the intervention group with the improvement of the glycemic control, all the symptoms you can see that statistically significantly improved. So the conclusion from that study was that continuous subcutaneous insulin infusion plus continuous glucose monitoring appears to be safe with minimal risk of hypoglycemic events, and associated not only with improvement on glycemic control, but also with improvement in gastroparesis symptoms. We did have quality of life questionnaires and Also improvement of the meal tolerance. And again, individuals were with fairly advanced and fairly severe gastroparesis, the ones who were enrolled to this study. So that was a study to support safety, feasibility, and potential benefit of improving glycemic control. So it was a multi-center trial. And again, that was one of the very few studies that actually have been done to look at the feasibility of tight control in patients with type 1 diabetes using with the improvement of hyperglycemia and hypoglycemia. So just a little bit on the treatment and prevention of hypoglycemia. There is no specific published guidelines on this topic, specifically for gastroparesis. Some studies looked at use of the regular insulin for less of the hypoglycemia than with 148. Oh, sorry, there are some echoes. So because of the sort of the low, the different kinetics of the insulin and slower onset of the regular insulin, especially in individuals with significant gastroparesis. From my personal observation recommendations, use of diabetes technology when possible, small frequent meals, small boluses, using lower fat, low fiber diet, extended boluses whenever possible, and can be canceled in case of the vomiting or not finishing the meal. Glucagon use for severe hypoglycemia, chewable forms of sugar rather than liquids, because again, the liquids empty pretty quickly in the stomach and it will be less of the predictable of the absorption because of this accelerated stomach emptying in the cases of low glucose. So I usually tell patients to have some sort of chewable sugar, always some gummies, jelly beans, glucose tablets, or Smarties, any kind of that sugar, pure sugar candies to get it done faster. I'm going to skip that slide because I think Dr. Wynn is going to talk about that. So for approach to therapy, again, glycemic control is important from my standpoint with the lifestyle modification, optimal meals, and composition of the meals important. Physical activity is very important, and evaluating of pharmacotherapy. Discontinuation, any of the medications that can affect gastric emptying, and assessment for other comorbid conditions. Look at hypothyroidism, look at other infections that could be present, any possible surgical conditions that could be taken care of. So those would be important. Now, switching to another GI very common issue in type 1 diabetes is a celiac disease. So prevalence is 6-fold higher in type 1 diabetes than in general population, and it's anywhere from 1% in general population to up to 16% in type 1 diabetes. So the recommendations from American Diabetes Association to check soon for celiac soon after the diagnosis, even if asymptomatic, and then repeat if symptoms occur. Check for the whole panel of antibodies. It's important to check for IgA antibodies to see even if the antibody testing is interpretable. Because of that, if the level is low, then we cannot really interpret other antibody panel. Clinical manifestation can vary a lot. It could be from any GI symptoms to be totally asymptomatic, to be completely non-gastrointestinal symptoms such as osteopenia, anemia. We are finding when we're doing osteoporosis and osteopenia workup, we're finding a lot of the patients with the celiac positive. So suggested algorithm again would be to check for if there are no symptoms, then check for the special antibodies, and if there are continue to be no symptoms, repeating per American Diabetes Association, repeat every 5 years, even if there are no symptoms. If there are symptoms and antibody negative, then consider small bowel biopsy. We can do the HLA typing for genetic screen for celiac, It doesn't tell us if person has celiac, but it tells us if the person is at high risk. And if it's positive, then repeat screening more frequently than every 5 years. So we do have a study, and I just put the flyer if anybody is interested. If anybody has celiac with type 1 diabetes and gastrointestinal symptoms and you're interested to participate, we are doing a study in type 1 diabetes for celiac disease, and you can, and I'm happy to share the flyer if anybody is interested. Nora is our coordinator who can screen and see if you qualify for that study. So we're using completely harmless supplement that kind of binds the gluten in the gut and does not let it get absorbed. Now, we are talking about, and I'm almost done, so a couple more minutes and I'll be done. And we are talking about endocrinology or endocrine pancreas in type 1 diabetes, but there is a lot of underestimation of the role of the exocrine pancreas, which is extremely important because endocrine and exocrine pancreas are neighbors, and the cells are located right next to each other. And it had been shown that exocrine pancreas actually constitutes a larger part of the pancreas itself. And it had been shown that in type 1 diabetes, the pancreas volume overall, it's much smaller than in controls and in type 2 diabetes. And there's quite a few studies, and I did the whole big grand round on this of the combination of the exocrine and endocrine in type 1 diabetes. And the exocrine pancreas, there are some studies that showing that exocrine actually can come first. And there are certain antibodies to the exocrine pancreas that can trigger the whole inflammation and the whole immune response into the endocrine pancreas, in the beta cells. And it's an alteration of the whole gland. It's not just endocrine pancreas. It's both endocrine and exocrine. So that is important to know. I think it's very, very underestimated. And there are, some questions. What comes first? Is it chicken or the eggs? What is coming first? So is it the endocrine pancreas responsible for, or if it's the exocrine? And there are some pros and cons for each one. So there are some pros that endocrine can be first and triggering exocrine pancreatic insufficiency with endocrine dysfunction, with vascular damage, with autonomic neuropathy. Or it actually could be exocrine because, again, as I said, those antibodies to exocrine protein are more commonly found in type 1 diabetes and actually found even before the antibodies of actual type 1 diabetes had been discovered. So there is also genetic predisposition, and there is a reduced beta cell survivability in inflammatory state in individuals who start with the exocrine pancreatic insufficiency first. So again, a lot of this is not known, and there are unfortunately more questions than answers in this topic. But as you can see, that the prevalence of exocrine dysfunction in type 1 diabetes consistently had been found a lot higher than in general population. So that link is also important to remember that that is not just gastroparesis, but it could be other conditions, again, combination of exocrine and endocrine pancreatic insufficiency. So from clinical standpoint, so patients may have at least one of the GI symptoms. Some fatty stool or steatorrhea can be present in up to half of the patients with type 1 diabetes, and 50% could be asymptomatic. But some can present with some diarrhea, bloating, cramping, or some weight loss. But again, some could be completely asymptomatic. Differential diagnosis would be gastroparesis, celiac disease, or small intestinal bowel overgrowth, which Dr. Wynn is going to talk about. So in conclusions for this kind of part of the talk is that the link between exocrine and endocrine pancreas is very, very important. Prevalence of exocrine dysfunction is really high in type 1 diabetes comparing to control. And exocrine changes resulting in some of the disruption of the islet function and due to the damage, but this is again under the debate. And they are alterations in the exocrine pancreas actually can precede the development of type 1 diabetes. And it's important and unrecognized. And there's only all these factors that can affect, this is actually from Diabetes Mind, how many factors can affect the blood sugar control. So go figure, unfortunately, there are so many different things that can be happening. So the exocrine and endocrine pancreas are linked, and there's much more to be learned on this, but there's definitely convincing data about the two being together and working together, and one triggers the other or one makes the other worse. So again, there are more questions than answers. We are part of the, Stanford is a part of the NIH consortium for type 1 diabetes and acute pancreatitis. So we're trying to collect that data. So there are, I think there are 14 or 15 institutions involved throughout the country. So we're trying to collect that data to get more answers to this question. And thank you so much. I think I'm gonna stop at this point. I do have more information about the coverage of the meals, but with gastroparesis, but and with different GI issues. Maybe we can talk about this after, or maybe I can show when we have some questions. And I will give the stage to Dr. Nguyen to talk about her.
Thank you, Dr. Basina. An endocrinologist who knows a lot about gastroenterology, more so than many gastroenterologists even. So let me, hopefully I can share my screen appropriately here. Okay. Are you seeing this correct screen, or are you seeing it in reverse?
We're seeing the presenter view.
Okay, let me swap in. Hopefully that's the correct one. Okay, so what I thought I would do today is just give more of a general overview of GI manifestations of diabetes in general. With the caveat that individuals with type 1 diabetes who typically have lived with diabetes longer than type 2 diabetics are more likely to be affected by any of these GI conditions when you compare with type 2. So I'm going to take a step back a little bit here to help illustrate why GI manifestations are so common in those with diabetes. So on the left, what you see are the nervous control, or how the nerves of the gut are controlled, or the function and sensation. And there are nerves within the lining of the GI tract, the enteric nervous system. But you also have the autonomic nervous system, which is the vagus, which is the parasympathetic, and then you also have the sympathetic pathways, which is through the spinal cord. And as you can see on the diagram from the left, that this really controls the autonomic nervous system, controls the GI tract from the esophagus all the way down to the anal rectum. And on the right side, it's a complex diagram, but really it's there to illustrate the complexities of the control of gut function and sensation. And we take it for granted that when we eat, the only thing that you really truly choose is what you're going to eat. You chew it and you swallow it. Once you do that, your GI tract takes over, and then in terms of the digestion, absorption, and elimination. But when those functions go wrong, that's when we start to notice. And Dr. Basina talked a lot about the stomach and diabetic gastroparesis, which I'm glad there's been increased recognition. But I'm going to really focus on the lower part of the GI tract where there's less recognition of that. And you can see here, as I dial down into the colon, that you also have this complex regulation of colon motility and function with the autonomic nervous system, with the vagus and the sympathetic nervous system. So if you have autonomic neuropathy, which is common in diabetes, it can affect the entire GI tract. And as you can see here, and this is my kind of simplistic diagram of the autonomic nervous system, you have your sympathetic, which is your fight or flight. So if you're being chased by a snake or a bear, your sympathetic nervous system increases. And then once the bear is gone, your sympathetic nervous system goes back down. The parasympathetic nervous system is your rest or digest. So when you eat, the parasympathetic nervous system increases. So there's always that kind of up and down, that seesaw balance there. And what you get is that when the sympathetic nervous system increases and it's chronically increased, where it doesn't come down, you get increased cortisol, mast cell activation, release of neurotransmitters, release of cytokines, and changes in the diversity of the microbiome. So you can see how if there are chronic stress or chronic increases in the sympathetic nervous system, it can affect the whole system. And when the sympathetic nervous system increases, or there's a decrease in the parasympathetic nervous system, again, you can have changes in gut permeability, increased secretions, changes in sensation, and the motility of the gut. And one of the challenges of dysautonomia or autonomic dysfunction is that's not just the heart, it's not just the gut, but you can see here on the right panel the number of visceral organs that are affected. So oftentimes patients with autonomic dysfunction or autonomic dysregulation come in with multiple symptoms. And when you go see specialists and you've got multiple symptoms, it's hard to pinpoint. And it can be overwhelming for the individual as a patient, but it can also be overwhelming for a physician who's trying to connect all the dots. And autonomic abnormalities have been frequently described in conditions like gastroparesis, functional dyspepsia, cyclic vomiting syndrome, and irritable bowel syndrome. This is a study that we did with the NIH Gastroparesis Consortium, where we looked at heart rate variability, which is a measure of autonomic function, and we correlated this with gastric emptying. And in a nutshell, what we found was that in patients with delayed gastric emptying, we saw one type of pattern of heart rate variability. In those with more severe symptoms, we saw more parasympathetic hypofunction. In those with mild symptoms, we saw sympathetic hypofunction. So what that tells us is that in those with nausea and vomiting, it might not be just the stomach. So when someone comes in with nausea and vomiting, we often focus on the stomach because when you vomit, you're vomiting contents from the stomach, but it might not be the stomach. The stomach emptying and functioning may be okay, but it's an issue with the autonomic nervous system. When you look at it on the converse side, when you take individuals with autonomic dysfunction, GI symptoms are common and it can affect up to 80% of patients. And nausea is the most common symptom, but you can also see abdominal pain, diarrhea, bloating, constipation, weight loss, chest pain. And on the panel on the right, what you see are common symptoms in patients with diabetes. And again, it spans the whole gamut of the GI tract. And in this column here, you see that in those with poor glycemic control, you're more likely to have the GI symptoms. I'm going to focus here on the lower GI symptoms because they don't get a lot of press time when you talk about diabetic complications, even though it affects almost 30% of individuals, whether it's diarrhea or constipation. So let me start by just getting us on the same page about certain conditions and diagnosis. You often hear us or individuals throw around the term irritable bowel syndrome or IBS. And it really is a syndrome. It's a symptomatic diagnosis. There's no blood tests or imaging or endoscopy. And it's recurrent abdominal pain that's associated with a change in the bowel function, or stool form. So if it's infrequent or hard stools, it's IBS constipation. If it's frequent bowel movements or watery loose stools, it's IBS diarrhea. And IBS is a disorder of the GI system where it's due to disruption in a combination of things: the microbiome, the nerves of the gut, the autonomic nervous system, the immune cells locally in the gut. And when you think about the different areas that are affected, you can understand why someone with diabetes is more likely to have symptoms of irritable bowel syndrome. In general, when you think about IBS, whether it's constipation or diarrhea, 60% of individuals report that their symptoms are worse with eating. And it doesn't really matter what foods, but common foods that commonly trigger IBS symptoms are foods that are fermentable, not fermented foods, but foods that tend to produce more gas. So gluten, wheat, lactose, fructose, fructans, which are in onions. Different diets that have been shown to help decrease symptoms are eating smaller meals, avoiding fat, increasing fiber, with a caveat that fiber can help with the stool form, but fiber can also worsen gas and bloating, and then avoiding dairy products. Peppermint has been shown to help with IBS, whether it's diarrhea or constipation. And the most common symptom it helps with is the pain and the bloating and kind of the distension aspect of it. So this can be in the form of peppermint oil, peppermint tea. This is a study looking at enteric-coated peppermint oil taken before meals to kind of help with the symptoms after eating. And in terms of general approaches to the abdominal pain aspect of it, whether you're talking about IBS or talking about the gastroparesis symptoms, we use a lot of neuromodulators, which you're familiar with this term in the diabetic neuropathy world. So very akin to diabetic neuropathy, I think about abdominal pain in the gut as diabetic neuropathy, but of the nerves of the gut as opposed to the nerves of the fingers and toes. And there are different classes of neuromodulators that can be used. The most common are the tricyclic antidepressants like amitriptyline, nortriptyline, diazepamine, but those also have effects on the GI function, like slowing motility. So if someone already has gastroparesis, I would not use that. But if someone was having diarrhea, I would use the tricyclics. Then you have the SSRIs, SNRIs. So again, not necessarily to say that, to go over each specific therapy, but for you to be aware that there are multiple classes and they each have different effects on different GI function. And as you think about if you're going to use these medications, is there an added benefit or is there a side effect that you want to be aware of? And then, we talked about kind of the pain and bloating with IBS. Then you treat the bowel symptoms. So in those with diarrhea, there are kind of general approaches. There's the non-medicinal approach, so exercise. In IBS, there's been studies looking at yoga and Tai Chi. Both of those things decrease your sympathetic nervous system, and that has helped with IBS symptoms in general. Sleep, so disordered sleep, whether it's frequent awakenings, difficulty falling asleep, any sleep disorder is associated with worsening of GI symptoms, including IBS. So, if there is disordered sleep, to improve on sleep. Diet, so adding soluble fiber. Oftentimes individuals will tell me that, oh, I eat a very healthy diet, I eat a lot of fiber, but most of what we eat in terms of fruits, vegetables, those are insoluble fiber. So you have soluble and insoluble fiber. The soluble fiber, think of it like the glue. It holds water, holds stool together. In general, you want to aim for about 25 grams of fiber per day with a good mix of 40 to 50% of soluble fiber, but make sure you also drink fluids with the fiber. Identify food triggers, especially with diarrhea. You want to minimize sugars, including the added or synthetic sugars, alcohol. Pelvic floor physical therapy. Oftentimes, the frequent bowel movements is not because of the diarrhea per se, but because the pelvic floor muscles are not relaxing appropriately, and that can lead to trapping of stool. Medical therapies, we talked about fiber. Then there's the antidiarrheals, antispasmodics, which peppermint is one of them. And then there's medications that can be used to slow motility. And then in worst case scenarios, especially in patients who have severe fecal incontinence or completely debilitated, one can do surgery to create a colostomy. That's very extreme and very rare that needs to be done. This diagram here, again, is not to say that there's one specific therapy that is, better than the other, but this tells you that there is a range of different therapies with different mechanisms of action that can be used for IBS diarrhea. So if one therapy doesn't work, that doesn't mean that you necessarily need to stop. And sometimes when the diarrhea is severe, you need to use multiple therapies with different mechanisms of action to overlap. So here you see different categories of therapies. You would not want to use two therapies in the same category, but potentially use overlapping therapies. And kind of stepping back a little bit in terms of the diarrhea aspect of it, because rapid gastric emptying can lead to diarrhea, especially diarrhea after eating. There is an anti-anxiety medication called buspirone, which works on a type of serotonin, 5-HT1, by improving the relaxation of the upper part of the stomach. So that can help slow down stomach emptying and diarrhea. But also what it does is it helps decrease the sympathetic activity. So if there is an increased sympathetic tone that is associated with the diarrhea related to the autonomic dysfunction, buspirone can be a medication that is targeting the stomach and the autonomic nervous system, but can have an improvement in the lower gut. Now, what if you try all these therapies and it's not working? So in those individuals, I would consider small intestinal bacterial overgrowth or SIBO. And what is SIBO? Essentially what it is that our digestive system, from the mouth, esophagus, stomach, small intestine, there are bacterial compositions there. And in the stomach and upper part of the small intestine, there are fewer bacteria than there are in the lower small intestine and colon. What bacterial overgrowth is that there is an abundance of bacteria in the upper small intestine. And what happens is then when you eat foods, especially carbohydrates and sugars, these bacteria will ferment these carbohydrates, these sugars, and produce hydrogen, methane gases, and other acids that can lead to abdominal pain, cramping, bloating, diarrhea. And so we can test for bacterial overgrowth. The most common modality is doing a breath test. And the two most common ones are lactulose and glucose, where you drink the sugar and then you essentially breathe into a tube or a bag every 20 minutes for 3 hours. And this sugar is, when it's fermented by bacteria, there's hydrogen, potentially methane, and carbon dioxide that's released and is picked up in the breath. Cultures can also be obtained through endoscopy, but it's more invasive and more difficult to do. And there are some breath tests that can be done to test for carbohydrate malabsorption. The most common ones are lactose, sucrose, and fructose. And so this is something that you can talk to your physicians about getting tested for if the treatment for IBS is not effective. And what are some of the treatments for bacterial overgrowth? The most common ones are antibiotics, which work about 50% of the time. So there's no, unfortunately, there's no one therapy that is 100% effective in bacterial overgrowth. But there are various antibiotics that can be used, and depending on whether it's hydrogen or methane producing, sometimes you need to use combination therapies. Going on the other side for chronic constipation or the IBS constipation, again, there are non-medicinal therapies. Exercise, diet, we talked about, very similar in terms of the impact of yoga and Tai Chi, but also walking can help in the setting of constipation. I mentioned briefly before pelvic floor physical therapy because the sphincter is not relaxing. These are oftentimes the symptoms are straining, incomplete evacuation. So one feels that the stool that there's stool there in the rectum, but nothing comes out. So you can use a squatty potty, which is basically a step stool that has a carve out that allows you to bring your knees up into a squatting position. So if you think about early humans, we really weren't meant to sit on toilets. So sitting on the toilet actually changes the anorectal angle, and it makes it harder to have a bowel movement. And even for those of you who don't suffer from constipation, if you want to time yourself having a bowel movement, sitting on a toilet versus using a squatty potty or squatting, you'll find that you defecate faster in the squatting position. And then there's the medical therapies, again, optimizing fiber, using laxatives, and then motility agents. Oftentimes, I'll have patients use, suppositories, enemas, and worst case scenarios, so surgery. And one of the biggest misconceptions about constipation is this concept that, if you use these laxatives or these enemas, that you'll become dependent on it. And that's really a misconception. It's not that using these therapies is causing your colon to not function. Your colon is not function for one reason or another. In this situation, it's diabetes. And so you need these therapies. It would be like telling someone with high blood pressure that if you take this blood pressure medication, you will become dependent on blood pressure medication. And again, similar to the slide I showed with diarrhea, these are different classes of therapies that are available for IBS constipation and chronic constipation. And again, sometimes you have to use them in combination depending on the severity. And just one therapy I wanted to call out is pridostigmine, which is an acetylcholinesterase inhibitor, and it's used in autonomic dysfunction to increase the parasympathetic activity. And this is a study that basically showed that pridostigmine does improve the constipation, and no matter how you look at it, with either the stool form, weekly bowel movements. So in my patients who have constipation and autonomic dysfunction, especially parasympathetic hypofunction, I'll often use pridostigmine as opposed to one of the more traditional medications for constipation. So in summary, I just want to say that GI symptoms are common in patients with diabetes. Gastroparesis gets the most attention, but it's only one of the various complications. Poor glycemic control can affect nerve function in the gut and the autonomic nervous system, which is what gives rise to all these GI symptoms. To start, glycemic control is the mainstay of therapy. So improving the glycemic control can improve GI function all around. But especially, for example, in someone with diabetic gastroparesis, if you're vomiting and you can't control your blood sugars, you have to help control the GI symptoms in order to help our endocrinologist control the diabetes. So you do get into a vicious cycle. So you have to treat the symptoms. And really, there's no one size fits all in terms of therapy for any of the GI disorders. You have to tailor the treatment based on the predominant symptoms and the needs of each individual patient. So with that, I end and happy to take questions.
Lots and lots and lots. And by the way, lots of questions and reasonably so. So I'm going to start out and then I'm going to toss it to the co-moderators. Because as I watch this, I have this overwhelming sense of being overwhelmed. Because there's so many parts of it, there's so many ways to look at it. And my experience with a probably high level of medical care in a sophisticated area doesn't have this knowledge. And the only place I see this is maybe at university levels. The complete care and the complete knowledge. I'm lucky if I find in a metropolitan area one doctor who understands motility, but who doesn't understand gastroparesis, and someone else who says gastroparesis, no big deal, why are you upset? How do you see this scaling for people who need this?
That's a very good, that's a great answer. And I think that there has to be multiple facets of this because this is a complex issue. It requires complex solutions. And unfortunately, part of the challenge is that, GI motility is not a sexy field to go into. There's nothing to cut out. So, our surgical endoscopists cut things and it's very satisfying. Mm-hmm. But also it's poorly funded. So if you look at inflammatory bowel disease like Crohn's or ulcerative colitis, there's a lot more funding there at the NIH level and from pharmaceutical companies than there are for irritable bowel syndrome, which if you look at globally affects about 6% of the world. So I think there's the research funding part of it. And then from, if you think about from insurance company standpoint, as a physician, I get paid more money doing a colonoscopy than spending an hour talking to a patient. So there's not a lot of motivation there for people to go to, enter this field. But I think we're getting there. I mean, in the 13 years that I've been at Stanford, we've gone from one neuro GI doctor to 10 now. So the field is growing and it will continue to grow. I think we need to have support from industry, government, and from patients.
Okay, I love that. I was waiting for you to say that because I'm really involved and several of our moderators are involved in advocacy. What can we do? I can be a loud voice. I know Teresa can be a loud voice. And I think this is urgent because the quality of our life is so impacted variably and unpredictably. What can we work offline and with you just to guide us on where we can make things start to make noise?
Yeah, definitely. But just an example, the NIH supported Gastroparesis Consortium, which is now in the third cycle of funding. So this is, I think, year 12 now. I was involved in the first 10 years. It started with patient advocacy, going to the NIH, demanding, needing, asking for this type of funding. So you do have a voice, and we see this with the Gastroparesis Consortium.
I think the biggest problem is, as you say, it's not a sexy one, and I had no idea he would even show up today because people talk to me they don't want to be seen here. So I understand how difficult it. Thank you, first of all, for doing what you do. I'm amazed. I'm going to turn this over. I don't know, Teresa, if you're ready to jump in, or Rachel or Barry, you can turn your cameras back on so Dr. Wynn can see who you are, and start lobbing her some questions. And if you want me to start, I will. Waiting for somebody.
Yeah, I can start. I think just so everybody's on the same page initially, maybe there was a question early on about what is gastroparesis. So I'm wondering if maybe either Marina or Linda could maybe give a short explanation of what it actually is and what it means.
Yeah, so gastroparesis is basically slow stomach emptying. So your stomach is not digesting food appropriately. And there are lots of different things that can cause the stomach to empty slowly. But because the stomach empties slowly, it can lead to symptoms of nausea, vomiting, feeling full early, abdominal pain, bloating.
Thank you. And then another question that Joanne actually had that I'm kind of curious about myself too is, we know that the beta cells are what produce amylin, but can we actually have our amylin levels tested like we can have our, our insulin levels tested by doing, my mind just went blank. I can't remember what the test is called. The lab test to see how much natural insulin production we have.
C-peptide.
C-peptide, yes, that's what I was looking for, but my mind just didn't want to bring it back. But is there a similar test to see if we can know how much amylin we're producing?
I'll punt that one to Dr. Basina.
Yeah, thank you. So it's a great question. I don't think we have any way of measuring amylin, at least commercially available. There's no test that we can order in clinic to be to measure. It's just sort of a extrapolation. If person has the insulin deficiency, because insulin is co-secreted with amylin, but amylin concentration is way smaller than insulin, and therefore there's usually decrease in the amylin as well.
Okay, here's a toughie, because I don't know the answer. Have you heard of gastroparesis being triggered by the use of Victoza in type 1 diabetic with insulin resistance from PCOS? I was vomiting everything while taking this drug, and after several months stopped because it was severely affecting quality of life. I won't go into all the details on that, but does that question make sense to you?
So it's a tough question because I don't think we have a direct measurement of that. So somebody, for example, so we do know that glucagon-like peptide, the whole class, the gastric symptoms or the GI symptoms are very common. I don't think we had measured whether this is just due to gastroparesis or some other, just other stomach side effects that this class of medication has. And it's very common, and there's a quite high percentage of individuals participating in the study with either long-acting or short-acting GLP-1 had the same symptoms. So I'm not sure that's exactly triggering gastroparesis per se, but it's just overall GI symptoms. So I don't think we have that proven data that it actually triggers it.
GLP-1 agonists do slow gastric emptying to a degree, and that's the idea that's slowing that rise in glucose after eating. So it doesn't cause like irreversible gastroparesis. If you already have delayed gastric emptying, it can make it worse and unmask the symptoms. Because oftentimes patients with diabetes, especially type 1 diabetes, have relatively asymptomatic delayed gastric emptying. So the stomach emptying is slow, but you have minimal symptoms. And one of the early signs that someone with type 1 diabetes may have gastroparesis is all of a sudden your glycemic control is wonky. You're doing fine, then all of a sudden you have these, off the chart highs and then crashing lows. And if someone's been doing fine, but then all of a sudden the glycemic control is off and there's no infection or anything else to explain it, the gastroparesis may be an issue.
I just want to jump back in, and then Barry, I see you on. Someone asked, and just clarifying, is the incidence of 40% of type 1 diabetic patients with a high mortality rate at 4 years? Someone heard that. She said she's Googling on NIH. Is that a correct statement?
Yeah, I think Dr. Basina, you shared a slide saying that the mortality rates range from 38% at 4 years to 34% in 25 years. So I think the questioner wanted more clarification on that.
Yeah, so this is not just for someone with isolated gastroparesis. This is more from their just overall autonomic dysfunction, and mostly the mortality is related to cardiac autonomic dysfunction. So this is what more commonly we've seen. But what we do see, if there is one organ autonomic neuropathy, then those individuals usually present with other internal organ autonomic neuropathy. So again, cardiac autonomic neuropathy would be more common in someone who has gastric autonomic neuropathy. So it's sort of overall, not just isolated gastroparesis.
I've got a question from a listener that hits close to home. Please discuss exocrine pancreatic insufficiency. I was recently diagnosed with this digestive condition. I am on enzyme replacement therapy. And I will throw in, so am I, and I had a great deal of difficulty getting diagnosed and had innumerable tests where they ran off in the wrong direction. And even now I'm a little bit unsure that I am on the right track as to when and how much enzyme replacement to take. It seems difficult to find someone that is, knowledgeable enough, whether it's a gastroenterologist or an endocrinologist.
Right, I can take that one. So exocrine pancreatic insufficiency, there's a lot of, it mimics a lot of symptoms, with IBS being the most common: gas, bloat, cramping, diarrhea. And you have to have a high index of suspicion. And the parts that make you, the other symptoms that make you think about or worry about exocrine pancreatic insufficiency as opposed to IBS without the EPI is weight loss, and in a type 1 diabetic. So if I have someone who's type 1 diabetic, then the EPI moves up higher on the list. You can do a stool test called a fecal elastase, which basically is a stool test that measures one of the pancreatic enzymes, and if it's low, then you treat with pancreatic enzymes and with a low-fat diet. So that's the science part. The art part is that, taking pills, it does not, the pharmaceutical world does not do as good of a job as your native pancreas in terms of determining like how much fat you eat and how much enzymes to produce. So then it becomes sort of a guessing game. So if you eat, again, it depends on how high or how low your elastase is when it's checked in the stool. It is, if you eat a high fat diet, you need more enzymes. If you eat a snack, you need lower enzymes. One way to try to gauge if you're doing it right or not is doing a fecal fat quantification. So you can check and measure how much fat is in your stool as you're eating your diet and taking the enzyme. And if you're not producing excess of fat in your stool, then you're taking the right amount. Now, just because you have EPI doesn't mean you can't have the other issues related to diabetes in the gut, so that the residual or ongoing symptoms, even though you're taking the enzymes correctly, may be due to something else going on: bacterial overgrowth, irritable bowel syndrome, diabetic colopathy, etc.
Thank you.
So we had a question about the stomach emptying test. And so I was hoping you could tell us exactly how that's done, so that maybe if someone wanted to advocate for themselves to get that test. And also I saw on your slides that a 4-hour retention of greater than 10% was part of the definition. And someone was asking if greater than 16% is considered high, or if there's some kind of gradient after this 10% that they should be concerned about.
Yeah, so in the US, the most common test used to diagnose gastroparesis is through the nuclear medicine department. I call it green eggs and ham minus the ham, but it's essentially egg beaters that has some technetium cooked into it with 2 slices of bread, with some jam and 8 ounces of water. And it's a low fat, it's a relatively low fat, low fiber meal. So we can debate about whether that's the right meal or not, but that was the meal that was studied, and that's the standardized meal. So that's the meal. You want to do a test that measures gastric emptying over a minimum of 3 hours, generally 4 hours. There are many centers that will do a gastric emptying test over an hour or 90 minutes. It's a useless test. You're exposing yourself to radiation, and the test is meaningless. The reason for that is that the first 30 minutes after you eat, it's the accommodation or titration phase. So that's when your stomach is relaxing, storing the food, grinding it down to a small particle of less than 2 millimeters. So there's very minimal emptying that's occurring in the first 30 minutes. So if you're measuring a gastric emptying for 60 minutes, you're getting no emptying for 30. And so then you can get a misdiagnosis of gastroparesis. In Europe, they do a breath test. And then you might see a smart pill test, which is a capsule test that measures transit through the gut. But the most common test is the nuclear medicine test. And you want to make sure that the meal that's being consumed doesn't necessarily have to be the egg beaters and bread, but it has to be similar in terms of caloric content and calories. So you want the same amount of fat, protein, carbohydrates. Because if you deviate, then that can change the emptying.
Great, thanks. That's a really great background. I was not familiar with this test before you just said that, so thank you.
There's go ahead, Joanne.
No, go ahead.
Oh, I was just saying there's 2 kind of related questions, so I'm just going to ask them at the same time. They're actually from the same person, but Anne wanted to know first if her daughter's feelings of constant hunger are due to lack of amylin or gastric emptying issues. What kind of doctor should kids see specifically about these kinds of issues? And also, what do you recommend for young people to prevent future gastro problems, or young people with type 1 to prevent this from happening?
I can't answer the amylin issue, but kind of constant feeling of hunger, there's so many different things that can go with it. If there's fullness, fullness of small milk, it might be due to rapid gastric emptying. I would start by seeing the endocrinologist, and then potentially pediatric gastroenterologist. The mainstay of trying to prevent any complications with autonomic neuropathy or GI is tight, good glycemic control, and that's really the only thing that has been shown thus far.
As just a side note, would you say time in range is more important, or just a good A1C is probably sufficient, or do we just not have enough data to differentiate the two yet?
I can probably take that question. So I don't think we have enough data. That's why time in range has not been as a standard test, because first of all, that we not able, unfortunately, to get continuous glucose monitoring devices for everyone. And that's a big issue, that we don't have a long-term outcome data with use of time in range comparing to A1C. So, and what we have is A1C correlating with the hard outcomes, which is not a perfect test, as we know, because there are a lot of issues when A1C does not really reflect that glycemic control. Yeah, but definitely, as Linda said, that glycemic control to start early in life, that's important. From all our studies looking at diabetes control and complication trial, DCCT trial, and EDIC trial, we do know that even the first several years, like in DCCT, the first 6.5 years being in tight control is important, even looking at 30, 35 years down the road in duration of diabetes with reduction of all the complications.
Is there I've heard that at say 20 years, if you have no signs of diabetic retinopathy, that your risk of developing it are pretty minimal. Is there like a time frame that if you're, if you've made it 20 years with type 1 and you have no signs of, GI issues, are you less likely? Or I guess I'm trying to get some hope for some of us long timers that, haven't had anything yet, but are still kind of worried about our early years, not having very good control.
Yeah, I think that's an amazing question. And that's what Jocelyn Diabetes Medalist Study is trying to look and to see, right? So they're looking at the 50, 55 plus years type 1 diabetes, and to see why some individuals are really predisposed to develop all the complications and the others are not. So generally, we're considering 20 years plus duration in diabetes. So it's kind of the multifactorial, right? It's not just the duration. It's that we know for now we have a sort of a new risk factor for cardiovascular disease, for example, in type 1 diabetes, the age of the diagnosis. So we are getting more data that age diagnosis under 10 years old is more prone to develop complications, especially in cardiovascular disease, comparing to the ones who were diagnosed later in life. And this is from study, I think, looking at almost 30,000 type 1 individuals that was published in JAMA a couple of years ago. So it's a lot is unknown. So there is some data that someone who has even small amount of C-peptide present, those individuals have lower rate of all the complications comparing to the ones who are C-peptide negative. But again, in clinically, we see both negative and some positive individuals with great control and or not control, not developing complications, and somebody will be developing a lot unknown, unfortunately.
I'm going to jump into the looping world because a lot of this was advertised into the looping community. So there are some interesting questions. What does slow digestion look like to you on a CGM line? Is it a small bump after a meal and then a drop and then another bump? That her child seems to see strange patterns. And how do you manage insulin and bolusing? And there's another one. How long do you push out the duration of insulin when you have someone with slow digestion?
Yeah, so on CGM, we usually see, depending on the meal, of course, and depending on the pre-meal blood glucose. So we do see initial sort of dip in the glucose and then later rise, and sometimes even usually after dinner, sometimes rise close to the middle of the night. And that may happen 2, 4, or 6 hours or later after the meal digestion. So this is usually the pattern that we see on the CGM. So sort of fast drop in the glucose and then slow rise over the hours. And that could be one of the feelings of hunger, for example, if blood sugar drops pretty quickly after the after the meal consumption. And again, it depends on what kind of meal is consumed. How to deal with that? It's usually those extended boluses. On the loop, you can set up a different digestion pattern for the, like, for example, pizza type of duration of the insulin. So obviously there's no perfect algorithm, and loop also has some of the imperfect sort of giving you back the negative basal rates, right? So that's one of the slight disadvantages of the loop algorithm, because if you give yourself too much insulin at the beginning, your basal rate is suspended. So you're creating this negative basal that can come back to you later. And that's when you're already having some bolus being absorbed. And that's when you get this eventual insulin stacking and lowering the glucose too much. So it's hard to manage, but that's in general, it's just setting up for the longer duration of diabetes, longer duration of the bolus. But it also depends on what your blood sugar is starting the meal. So the higher the blood sugar starting the meal, the more insulin you should give upfront, because as we said, even higher blood sugar in the beginning of the meal by itself will slower down the gastric emptying. For example, our gastric emptying studies would be canceled if blood sugar is over, I think, 250 or 275, right, Linda?
Yeah,
because
275.
275. Yeah, so because that can create sort of this artificial gastroparesis. On the other hand, if you're starting the meal with the low blood sugar, that can faster empty your stomach, and that can, again, alter that, the food metabolism or food gastric emptying from the stomach. So it all depends. Usually I say the lower you start the glucose, the meal before the meal, start with lower percentage of that extended bolus upfront, or even delay the bolus a little bit, and the higher your glucose when you're starting the meal to give more upfront, and then lower amount as extension of the bolus. And I'm not saying that how important it is, the absorption of the insulin. So it's important to have your doctors and yourself to look at the sites, because no matter how wonderful our algorithms are, if the insulin is not getting absorbed, if there is a lipohypertrophy or scar tissue that this insulin is going to, this kinetics of the insulin would be totally changed, right? And what we're talking about, possible gastric emptying, may not be gastric emptying. It may be the insulin kinetic changes if you're infusing into the scar tissue area.
There seem to be a lot of questions, thank you for that, on type 1 diabetes and acid reflux. There is one from a mom who says her daughter gets nauseous after swimming. Is there a relationship? What is the relationship, and what, that's the other end. What do you do, and how is that treated?
I mean, so yes, acid reflux is common in diabetics. So in that table that I showed with the different GI manifestations, the esophagus is one of them. But also in those with delayed gastric emptying, that can lead to reflux also, because if the stomach isn't emptying, then it's the food is sitting in the stomach, and it can reflux back into the esophagus. So reflux and gastroparesis often go hand in hand, where there's a lot of overlap there, because it's essentially a plumbing emptying and pressure phenomena. Nausea with activity can be a number of different things. One, if you have slow stomach emptying, and let's say you ate and 5 hours later you go exercise, but there's still food in your stomach, then it would be akin to, me without gastroparesis exercising immediately after a meal. So that can cause, reflux and nausea. But the other part of it may have nothing to do with the stomach, but be more related to autonomic dysregulation. So exercise of any type increases your sympathetic tone. But if you have autonomic dysregulation, that can lead to changes in your heart rate or blood pressure, and give rise to nausea. So the different, the different monitors that are available now, like the Oura Ring, the Fitbit, the iWatch, all those things that you can use now in terms of the individual tech, I find it helpful in patients trying to tease out what I call central nausea coming from the brain or the autonomic nervous system from GI nausea by looking at the heart rate.
I've got a question I just added based on some of the articles that I was reading recently. And they indicated that gut flora disruptions and T1D seem to go hand in hand. Is there a particular probiotic formulation or something else that would help provide a better balance and perhaps help mediate symptoms that people get from that imbalance?
So that's a very loaded question. In that one, we know that, dysbiosis or the gut microbiome is associated with a lot of conditions. What we don't know yet is what's chicken and egg, right? Because it does diabetes and the oxidative stress of diabetes, is that affecting the microbiome, or is there something affecting the microbiome that is then contributing to the symptoms and even the metabolic derangements? And there's a lot of research that's going into this right now on manipulating the microbiome for different diseases. And where we are right now, it's too early to say. I think it's a hot field, it's a hot topic, and one day we may find ourselves manipulating the microbiome for different diseases. But right now, with the probiotics that we have that are available, they're unfortunately, when you pull the data, you're just pooping out dollars by taking probiotics. There was a study that was recently published coming out of Stanford by Chris Gardner and Justin Sonnenberg's labs looking at fermented foods. So, sauerkraut, kimchi, kombucha, etc. So I think they had individuals eat 6 servings of fermented foods per day, and that seemed to increase the microbiome diversity. So I think if you're interested in, healthy flora, I would suggest doing it more with foods, sleep, stress management, because stress, it can also affect your microbiome, as opposed to spending billions of dollars, which the probiotic field right now is a multi-billion-dollar industry with little data behind it.
I know we're running into beginning to keep you too long, but I'm going to take it to a little bit of a higher level on, let's talk about gut microbiome, because I've been posting a lot about that and not really understanding, should we all get a microbiome test?
The answer is no, you're wasting your money, because right now the microbiome test is looking at stool, right? And stool is the endpoint of all the microbiome of your esophagus, stomach, small bowel, and colon, and you get it in the stool. What we don't know is the dysregulation in the colon microbiome, or is it perhaps the small bowel microbiome? Then that's the issue. So right now, the stool tests are being done in research, so in the world of research, but as an individual, people get these tests done, they bring it to me, and I don't know what to do with it. I don't know how to counsel people other than what I just told you right now in terms of diet, stress, and exercise and sleep.
So as I read more, there are the effects of age and aging on the gut microbiome. First of all, what do we do? We can't stop aging. Are there things that we can do as we age other than maintain good control in terms of diet, what we should and shouldn't eat? Or is that another whole Zoom?
that would be another whole Zoom. And actually, if you're interested in that, I would suggest my colleague, Dr. Laren Becker, who is doing translational research in the field of aging, the immune system, and gut microbiome and motility. And, you know, in the rodent model, and I know none of us are rodents, but placing, you know, the aging mice with the younger mice seems to slow the process. So hang out with grandchildren, change lots of diapers.
And just gosh, one more, because this has been coming up as I read. How disruptive are things like artificial sweeteners? Are they things we should pay attention to as people with type 1 diabetes who can't add sugar but want something sweeter?
Stay away from artificial sugars, sweeteners, ultra processed foods. So again, when I talk about diet, it's eating sort of the not only fermented food, but whole foods, not necessarily at Whole Foods, but whole foods that are not processed, or minimizing the processed foods, and staying away from added sugars, but also the artificial sugars.
What's the risk of having artificial sweeteners? Because I mean, I personally, I really love my Diet Dr. Pepper, and that's kind of my go-to when I want something with flavor to drink that's not water. So what is the added risk for me doing that?
The thought is that it affects the microbiome in a negative way. But again, it's when you talk about, you know, when I talk about, you know, avoiding these ultra processed foods and artificial sweeteners, it's about moderation, right? So one Diet Coke here and there, it's not the end all be all. It's if you balance that with, you know, a healthy diet. So, you know, and I forgot who to credit this to, but I saw this on Twitter, is that, you know, eating a healthy diet doesn't mean you stay away from your burger. It's instead of the burger and fries, have a burger and salad. So have your Diet Coke with a salad, or have your Diet Coke with sauerkraut. You know, so where you there's a balance, because if you withhold everything that's pleasurable to you, you're going to feel like you're missing out, and then you're not going to be successful, because you'll end up going back and drinking that Diet Coke anyway.
I hear us T1Ds bargaining with you a little bit. So yeah, I like my Diet Dr. Pepper. I like my this. So the question comes, what about stevia or monk fruit, which are considered more natural? Please.
I mean, I can't, you know, there's no studies to say that one form of sweetener is better than the other. All I can say is moderation.
I was going to also add that, yes, definitely one size doesn't fit all. And some individuals may react more to those artificial sweeteners than others. Some may have more, because it's less of the absorbable sweeteners. So for some individuals, it can trigger more diarrhea, for example. And with the insulin, it may be harder to cover, because what exactly gets absorbed and what doesn't from other foods that are eaten at the same time with those artificial sweeteners. And some people would not have any diarrhea and would tolerate those well. So I think it's very individualized.
Okay. I from the bottom of my heart, thank you so much for your time. I want you all to go back to your research and taking care of people. We all want to be your patients, but thank you for your time. Thank you everyone for coming in today. Tough topic, important topic. So thank you all. I hope you all have a lovely evening, dinner if you're on the West Coast. And thank you.